The first malabsorption syndrome we have is the celiac disease. And basically, the celiac disease is sensitivity to the gluten. So any patient consume gluten or any foodstuff containing gluten, like bread, this causes sensitivity of his intestine and injury of the mucosal surface of the intestine, most commonly at the distal duodenum and proximal duodenum. So I remember it by this. At celiac disease, the part of the intestine that's injured is the distal duodenum, DD, and the proximal duodenum. So the ileum is not affected unless at severe cases. Okay, so the first part of the intestine that's injured at celiac disease is distal duodenum and proximal duodenum. Why this is important? Because the most food stuff like carb, protein, fats are absorbed at this area. So you will have fat soluble vitamin deficiency, but fat soluble vitamin deficiency like ADEK, which we remember it KEDA, and other fats will not be absorbed. So patient will have symptom of loss of these fats, like loss of vitamin K will cause intracranial hemorrhage, loss of vitamin E will cause ataxia and hemolysis, and neuropathy, loss of vitamin D will cause rickets, loss of vitamin A will cause night blindness, and also loss of fat in the stool that cause steatorrhea. Okay, so I will ask you a question. What about vitamin B12 absorption in patient with celiac disease? Is it normal or abnormal? Normal. Why? Because vitamin B12 is absorbed at the terminal ileum. Now, why patient with celiac disease may have neuropathy? Don't confuse. Neuropathy at celiac disease isn't caused by vitamin B12 deficiency. It's caused by autoimmune. Why autoimmune? Because actually, the pathogenesis of celiac disease is an autoimmunity. Autoimmune mediated intolerance of gliadin, which is gluten protein that's found in wheat, barley, and rye. And we know that autoimmune diseases come together. So if you have an autoimmune disease like celiac disease here, you can get any other autoimmune disease. What other autoimmune diseases you know, like thyroiditis, Hashimoto thyroiditis, vitiligo, alopecia, type 1 diabetes mellitus? Any autoimmune disease can happen if the patient have another autoimmune one. So most common cause of neuropathy in patient with celiac disease is autoimmune, not vitamin B12 deficiency. But what about cause of neuropathy in patient with Crohn's disease? Yeah, don't confuse. Crohn's disease affect mainly the terminal ileum. It's a escape lesion, but commonly affect the terminal ileum. And this terminal ileum is site for vitamin B12 absorption. So neuropathy at Crohn's disease is due to vitamin B12 deficiency, malabsorption. Also, terminal ileum is a site for enterohepatic circulation of the bile. So if terminal ileum is affected, the bile will not be absorbed. So this bile help emulsification and transforming the fat into more easier compound to be absorbed. So we have fat soluble vitamin deficiency as well a patient with Crohn's disease due to loss of enterohepatic circulation, no bile salt, no fat absorption. Now, what about folate? Does folate deficiency cause neuropathy? No. Both folate and vitamin B12 deficiency can cause megaloblastic anemia. But the difference is at folate deficiency, there is no neurologic symptoms, while at vitamin B12 deficiency, there is neurologic symptoms. The second thing is where folate is absorbed, it's absorbed at the jejunum, but where vitamin B12 is absorbed, it's absorbed at the terminal ileum. So this is very important to know. After we take this big picture of the disease and the common symptom of this disease, let's discuss it in details. So this malabsorption syndromes that contain celiac disease can cause diarrhea, steatorrhea, which is presence of the fat in the stool. So the stool float over the water, weight loss, weakness, vitamin and mineral deficiency. You know that mineral like iron is absorbed at the duodenum as well. So at celiac disease, that affect the distal duodenum, you may get iron deficiency anemia, and this is very, very important to know. So when you see patient with diarrhea, malabsorption, and iron deficiency anemia, think about celiac disease right away. This is very high yield. Iron deficiency anemia plus malabsorption, think about celiac disease. Iron deficiency anemia with malabsorption, a parasite is caused by ankylostoma duodenales. You are right. So ankylostoma cause iron deficiency anemia due to suckling of the blood, chronic blood loss from the intestine. You can screen for malabsorption syndromes by fecal fat test because there is steatorrhea, there is fat in the stool, and you can detect the fat by Sudan stain. Now, celiac disease, also called gluten-sensitive enteropathy. Celiac is pro because the enterocyte is sensitive to the gluten. It's autoimmune mediated intolerance of the gliadin, and this is gluten protein found in the wheat, barley, and rye. This disease is associated with HALA-DQ2 and HALA-DQ8. How to remember this? I ate too much gluten at Dairy Queen, so 8 for number 8, 2 for 2. Dairy Queen. This is obvious. And this disease is common at European descent. What other disease is common at European descent? Yes, it's cystic fibrosis. Cystic fibrosis causes malabsorption due to pancreatic enzyme insufficiency, and it's common at European population as well. The most common site affected by the celiac disease is distal duodenum, proximal duodenum, which is site for fat and folate absorption. So you get malabsorption of all food stuff, including iron. So you get iron deficiency anemia that causes microcytic anemia. So microcytic anemia plus malabsorption, think about celiac disease until proven otherwise. Steatorrhea is present as well, and you treat by avoiding of the gluten. Okay, so avoid gluten stuff, avoid the thing that cause hypersensitivity, and this is how we treat this disease. This disease is associated with dermatitis herpetiformis, which is herpetic-like lesions present on the elbow. This is the most common site for these lesions, and this dermatitis herpetiformis is IgA-mediated type 3 hypersensitivity. So IgA attack the antigen and precipitate in the skin that cause dermatitis herpetiformis. I will discuss the types of hypersensitivity in the next lecture. We have 4 types of hypersensitivity: 1, 2, 3, 4. 1 is common at anaphylaxis. 2 is common at antibody that attack antigen at its place, like rheumatic fever. Type 3, like immune complex reposition. So antigen, antibody that precipitate in the tissue and form complex. So complex start with C, which is the third letter of alphabet for type 3 hypersensitivity. And type 4 is common at which is called the delayed type hypersensitivity as well. Letter D is the 4-letter alphabet, so it's type 4, and cause diseases like contact dermatitis and graft versus host rejection. Also, we have decreased bone density due to loss of vitamin D, which is fat soluble vitamin. Iron deficiency anemia. This is very important. Very, very high yield. Iron deficiency anemia. There is increased risk of malignancy in patients with celiac disease, and the most common malignancy here is T-cell lymphoma. Why? Because actually this is an autoimmune disease. There is many lymphocytes at the anterior site. So this lymphocytosis, link it with the lymphoma you will get at this disease. So T-cell lymphoma is common at celiac disease. There is a test that we do to detect integrity of the small intestinal mucosa. This test is called D-xylose test. What is a D-xylose? D-xylose is actually monosaccharide. This monosaccharide doesn't need anything to be absorbed except intact mucosal surface. So if there is mucosal surface damage, this monosaccharide will not be absorbed, so its level at the blood will be low, and its level in the urine will be low as well. So if this D-xylose test is abnormal, like we detect low level of D-xylose test in the urine after we ingested it, we have 2 common reasons for this. The most common one is the celiac disease, and the second one is something called small intestinal bacterial overgrowth, because bacteria consume the sugar to grow. So when you take monosaccharide, the bacteria will consume it and its level will be low in the blood. So how to differentiate between this as a cause of low D-xylose test in the urine and the celiac disease, which cause injury of the mucosal surface and the low D-xylose test in the urine? This is simple, easy. Give the patient antibiotic. If the patient improve on the antibiotic, so you know that the cause was a small intestinal bacterial overgrowth. After we give the patient antibiotic, detect the level of the D-xylose test in there. If the level return to normal, so you know that the cause of the previous low level is the small intestinal bacterial overgrowth, not the celiac disease. But if the level of the D-xylose is still low after you gave the patient the antibiotic, so this means that the cause is small. So this means that the cause isn't small intestinal bacterial overgrowth, and there must be injury of the small intestine. So you suspect the celiac disease and rule out the SIPO. Also, to diagnose celiac disease, as we said that it's autoimmune disease. What autoimmune is present here? There is something called IgA anti-tissue transglutaminase. How to remember this? GLUT in its name help you remember the gluten sensitivity of celiac disease. Another one is anti-endomysial antibody. You should know this. There is no mnemonic for this part. The third thing is anti-deamidated ghaliarin peptide antibodies. You don't need to remember all of this complex name. Just focus on ghaliarin part to remember the ghaliarin and the gluten sensitivity of celiac disease. When you look at the enterosite on the light microscope or histology, you will find villus atrophy, loss of the villi. Okay, so you have loss of the villi, mucosal atrophy. Normally, the villi will be tall structure like this. So when you see blunting of the villi and the loss of this villi, suspect celiac disease due to mucosal surface injury. This crypt will have hyperplasia, and this area will have lymphocyte proliferation, increased lymphocytic count. So this is healthy villi, and this is the villus atrophy. You see there is blunting of the villi here, and there is crypt hyperplasia here, increased number of the enterocyte at the crypt area. And here is the mechanism of the celiac disease, which is sensitivity to ghaliarin and autoantibody anti-transglutaminase, ghaliarin endomysial antibodies. Thank you for watching. See you in the next one.